Hello, everyone. I don't know if you can hear my voice, but if you can hear my voice, just let me know. If you can hear my voice, the sound of my voice, just let me know. Just draw my attention. I can see some messages. Okay, hi, hello, bro. Okay. Thank you. Can you hear my voice? Okay, it's okay. Good. Good. So the discussion is going to be about um, constipation. I'm doing this whole thing. I did this video last year, and I'm doing it today as well for 2025. Um, but this one is going to combine both constipation with intestinal obstruction all together, because most of the times many people confuse constipation with intestinal obstruction. Many people confuse constipation with intestinal obstruction, and that is why we are here. So I would urge each and every one of you to take this very seriously, because I'm going to make sure that I touch on every detail that you would need. Trust me. I'll make sure that I'm going to touch on, because some of you have reached out to me um, and then expressed your problems with me. Say, like during school, because of this or that, you weren't able to study in school and all. So I'll just assume we are all starting fresh. And it's going to benefit me as well, because some of the things me I've forgotten them. So we are going to learn together. Okay, so intestinal obstruction is, we all know, intestinal obstruction is the sudden cessation or sudden arrest of bowel movements in the guts, including gases, fluid, and then solid materials. But let's touch on constipation first. So over here they are saying constipation. I'm using both STG and then some other stuff. So if you have the STG, the hard copy with you, I would recommend you get it. This is the STG, get this one. If you don't have it, try and get it. You can go to Kolibu or something, you get some there. Okay. So it refers to bowel movements that are infrequent, or stools that are difficult to pass. So the reason why this is even a medical issue is that when it comes to constipation, you only have to look for simple things, whether the person is hydrating well, or whether the person is eating raw veggies well, or lack of exercises. All those things can lead to constipation. So those are the basic things you need to look at. The other problem is to find out whether the constipation mixes up with diarrhea. Okay, let's say today the person has constipation, the next day he has diarrhea. So with those ones, you are looking at GI malignancies, and this can be part of the objective questions. They can say, because it's in the STG. Let me see this. They've indicated it clearly in the STG. They said diarrhea, which alternates with constipation, may indicate large bowel cancer, especially in those who are aged 40 and above. So they can say which of the following class of people are likely to experience constipation, constipation that's I don't even know the English to even use, which alternates with diarrhea. And then they can state the number of years: 3 years, 5 years, 3 years, 50 years, 90 years, 40 years and above. And then this one is going to help you. So constipation that alternates with diarrhea, okay, you have to think about GI malignancy. Okay, let's go on. So let's look at other causes. It will get interesting when we get to the intestinal obstruction, trust me. So I'll urge you to stick to this until we get to the end. And I'm going to give you hands-on information, things you are going to do when you even start working, what you actually do on the field, which is not in the book. Okay, when you have a child that has intestinal obstruction, what do you do? Okay, so those are the things you have to, how you examine the patient. All those things are very, very crucial and very important. So we have other medical causes that diet deficiency in roughages. I think I've explained that. And then we have hypothyroidism. Who knows the mechanism behind hypothyroidism? How does hypothyroidism lead to constipation? If you know, you can type it there. If you know, you can type it there. So hypothyroidism, what I have is that hypothyroidism, it slows down the contraction of the intestinal muscle, and then it also encourages reabsorption of fluid. So since there is contraction of the intestinal, it slows down the contraction of the intestinal muscles. So there is decreased proportion or movement of bowel in the of bowel contents in the gut. You understand? And that leads to excessive reabsorption of water in the gut, and then the feces becomes very hardened. That is the clear explanation. Also, we have the irritable bowel syndrome. It also follows the same mechanism. Irritable bowel syndrome follows the same mechanism. Also, we have the hypercalcemia. So you always have to remember, hypercalcemia, calcium and magnesium, they always alternate. You always have to remember. When you learn your basic, I don't know whether it's physiology or something, we are looking at the intracellular fluid compartment, the transcellular, and then the extracellular fluid compartments. Where does all those calcium and magnesium, where do they belong? You have to try and read again. Okay, and then we have so calcium, it causes the hypercalcemia, causes weakening of the intestinal muscles, which leads to poor motility of stuffs in the gut. We are also looking at drugs, medications. So a patient comes to you with constipation, and you ask the person, "Oh, are you suffering from Parkinson's disease?" Someone will also is standing beside you, be like, "Whoa, why did you ask?" Well, probably you saw some tremors and then some other stuff, and then you thought, "Oh, probably the medication the patient is taking is causing the constipation." And it is true. Some medications which are given to those patients end up causing Parkinson's disease. End up causing constipation. Also, someone can come in, you look at a person and say, "Whoa, do you abuse tramadol or any form of opioid?" The person tells you yes. So opioid use is also one of the main cause of constipation. In the clinical setting, those who suffer from constipation are predominantly those who are on morphine. So you give patients morphine, 5 milligram or 10 milligram, and then maybe for some sickle cell management or something. And then the next thing, they have constipation. And so you have to know that is a side effect of this medication. Once you withdraw the medication, you are good to go. Okay, so we have atropine, we have codeine, we have morphine, tramadol, antidepressants, and some other stuff. And then we have the lazy bowel syndrome, and this comes from those who like to use laxative. So let's say you train yourself with laxative all the time, every day you use laxative, and so you've trained your body to like laxative. So the day you not use laxative, or how do you call that thing? That thing we enema. You train your body with laxative and enema. So the time you don't use enema or laxative, you realize that you will start having constipation. In children, you also have to investigate dehydration and then starvation. Those are the most important ones. So with the surgical part, we are looking at anal fissures. When we say anal fissures, we are looking at the tearing or tears, okay, in the lining of the anal region. I don't know whether YouTube will allow me to say the anus. I don't know, whether YouTube will allow me to say that, but that is it, and it is very painful. And then so you have to look at perianal lesions. We'll touch on all those things when it comes to digital rectal examination. So we'll touch on all those things. And then carcinoma of the rectum, it could be the sigmoid colon or the rectum, Also in children, for example, you are looking at foreign body. So the child might be playing with a toy and then swallow the toy. The toy will go up in there and then boom, get stuck somewhere. So in children, you have to rule out foreign body ingestion. Also, we are looking at masses. So a mass such as uterine fibroid, and then fetus, all those things can cause how do you call it? Some form of obstruction in the stomach. So what are the symptoms? They'll tell you, oh, I feel there's inability to pass to. And you have to be really careful when patients tell you this, because sometimes some people will tell you, some people, okay, I wouldn't say me, okay. Some people, we do it once a day and we are okay. So if you don't pass through for like 2 days, then if I don't pass through for 2 days or 3 days, then there is a problem with me. But there are some people who can stay up to 3 days before they pass through, and with them, it is normal with them. It has been normal with them. So when you're dealing with a child, you need to ask the mother, how frequent does the child pass through? Is it every day or every 2 days? If mother says every 2 days, and now today is the 4th day that the child hasn't passed through, then you start investigating. Also, there is, with the symptoms, frequency, infrequent stools, straining to pass through, feeling or incomplete evacuation of the bowel. So after going to the loo, you realize that there is still something in there. Also, there is colicky abdominal pain. So, when you have a patient like this, when you auscultate, you have a high-pitched bowel sounds. So when there is a high-pitched bowel sounds, you have to look at mechanical bowel obstruction. And so when we go to the intestinal obstruction, I'll explain some of the mechanical bowel obstruction. We have 2 types. We have the mechanical and then we have the functional. With the mechanical bowel obstruction, we are looking at a lot of things. We are looking at hernia, we are looking at intussusception, we are looking at volvulus, we are looking at a whole lot of things. That is why when you have a patient like this, it's good to examine all the hernia orifices to be sure this doesn't happen. Okay, and then when it comes to, and when you auscultate and there is absent bowel sounds, then it means you are dealing with a paralytic ileus. Okay, and that is a functional problem. However, if you have a client and whilst you are palpating the abdomen, you realize that there is generalized tenderness, rebound tenderness, guarding tenderness. Those things are classical signs of acute abdomen. But because it is a case of intestinal obstruction, you are suspecting peritonitis. So those are the main things. Okay, so what are the investigations? What investigation should you do? So this is the most important part. If you have a client, especially for children, you don't use this finger. Okay, for adults we use the index finger. Make sure you wear 2 gloves, because there have been instances where people wore 1 glove, and the glove, after inserting their finger through, the gloves got torn, and unfortunately it was their right finger. So the right finger entered and then it got torn. The gloves got torn, and then they had fecal matter in their finger. So make sure you wear like 2 gloves. You apply some lubricant on your fingers, okay, on your index finger, and then you do, in the case where there is no lubricant, you can use normal saline, okay. But with children, you use your pinky finger. We don't use this one for children. We use this one, okay. You use your pinky finger for the children. So before you do any examination, you look at the anal region, okay. You look at the anus, okay. What are you seeing? Are you seeing any skin tag or anything? Are you seeing any lesion or anything there? That is one, okay. That is inspection. And so I don't think palpation and auscultation and all those things will be applicable here. But when you, after doing that, you also after sticking, so if it is an adult, okay, let's, with the children, okay, after sticking, okay, let's say an adult, right? After sticking wearing your glove, you wear 2 gloves, and then you add your KY jelly. When you put your finger there, you are looking at the tone, the rectal tone. That's the rectum. Does it grip your finger like this, in the sense that you try to, if there is some resistance when you try to remove your hand? So if it grips your finger, then there is good rectal tone, okay, good anal sphincter tone, okay. So you go in there and then you move up. You see, the military people, they don't use 10 left, or even though they use all those things, they use the clock sign. So the up clock, I think that is 12 o'clock, and then this side is 3 o'clock, and then here is probably a 6, and then a 9. So wherever you find any mass or anything, that is how you will indicate whether it was at 6 o'clock or 3 o'clock or 8 o'clock, whatever o'clock you found. And then when you are bringing your hand, you try to scoop some part of the fecal matter. So you have to have a look at it, okay. You look at it. Is it blood stained? Is it frank blood? Does it look like the blood is fresh, okay? And then does the blood appear, does it appear way too dark, like very dark, like charcoal? Okay, so those are the things you have to look at. Is it bright red? Does it appear too dark, or all those things? Those are the things you have to look at. And so when you are examining and the person appears to be an adult, you go, if this is the anus, okay, if this is the anus, and you slot your finger in, okay, you move your finger, this index finger, a little down, okay. When you move it down, you palpate the prostate. Can you see my finger? So once you insert, or should I do it like, no, like this. So once you insert your finger, you move it down a little, and if you have a benign prostatic hyperplasia or benign prostatic hypertrophy, once you insert your finger in and you touch, you will feel the mass. And now that you are feeling the mass, you have to tell us the consistency of the mass. So is the mass you are touching, is it soft? Is the mass firm, or is the mass hard? Those are the key things you have to look at, the consistency of the mass. So you have, and don't use lubricant, please. So you insert your finger, you palpate the mass. Is the mass firm? Is it soft? Is it hard? So how would you know if it is soft? You can touch, when you touch your lips, you see how your lips feel soft when you press your lips. That's how the mass, a soft mass, feels like. So when you do the DRE and you feel something there that appears like you pressing your lips, then that is a soft mass. When you touch and it feels like, touch your own nose, you realize that because of the cartilage, it's neither It's neither hard nor soft. Okay, so that is a firm mass. When it is firm, it feels like this. It feels like your nose. Okay, the hard one feels like your chin or your forehead. Okay, very hard, stony, very very hard. So that is it. So we are looking at calcification and all those things. Okay, all right. So that is just by the way. So in case you have a BPH case in the exams, with this clear explanation, we've touched on with intestinal obstruction and constipation. At least you've had a little feel on BPH and how to do digital rectal examination and the findings. So you only have to document what you touched, you palpated. Does it feel like very soft like your lip? Does it feel hard? Or does it feel like it is firm? Then you document, okay? And then with your investigation, you would have to do a full blood count, an X-ray, and this is where people get it twisted. You either do erect and supine or plain X-ray, okay? We don't do that. And you just go and write just X-ray. It means it's wrong. It means you are getting zero. Because X-ray, you write X-ray, and they don't know whether it's X-ray of the sinuses or X-ray of the femoral head, or you need to specify which part of the X-ray. Okay, sorry, don't be looking at my big tummy. I just finished it. Okay, so plain abdominal X-ray, and then you indicate erect and supine. So in every intestinal obstruction case, erect, plain abdominal X-ray into brackets, erect and supine, erection, erect and supine, erect and supine, erect and supine. I think the guys will understand what I'm trying to say. Okay, and so don't go ahead and be saying proctoscopy and all those things are for the surgeon to decide. Okay, yours is to conclude that this is an intestinal obstruction, or this is that. Okay, so when it comes to constipation, the treatment plan is just, you identify the cause of the constipation, and then you relieve symptoms. And then with a non-pharmacological treatment, adherence with exercise, eating of fiber diet, and it can shock you that this can come in the subjectives, it can come in the subjectives, and you may have to give three things you have to do when a patient, to help relieve a patient with constipation. And then this is, so exercising, intake of adequate amount of water. So STG, they said 3.2 liters water, but if you forget to quote that 3.2, just say adequate exercises, adequate fiber intake. Okay, because you have to apply your brain. If you cannot quantify, you've forgotten how to quantify it, or you've forgotten the figure, just put something reasonable there. Okay, so with the pharmacological treatment, we have a lot. Okay, you can give bisacodyl. We normally do 10 to 20 milligram. Okay, I think one tab is 5 milligram. You have the Sina, that one I think is 10 to 15 to 30 milligram. Yeah, and then the maximum dose you can go is 70 to 100 milligram. We also have the lactulose. Okay, we have the lactulose, and then we have the glycerol. I've used glycerol suppository before, and it works like magic. Okay, but you have to be careful when you write the glycerol. Some of them they'll go and get you paracetamol suppository. When you write glycerol, I've seen it before, so that's what I'm saying. So I wrote glycerol suppository, and they brought me paracetamol suppository. So you have to be mindful of those things. Also, you can use milk of magnesia, especially when you are dealing with children. Milk of magnesia, But milk of magnesia has two functions, and you always have to remember. So when you have the milk of magnesia and you have about 5 to 10 mils, you now have to, after you've taken, you pour, let's say 5, you have to mix it with about 5 to 10 mils in a glass of water. I don't know if you understand. 5 to 10 mils, you put it in a glass of water, and then the patient drinks. That is for, to relieve constipation symptoms. But when it comes to diarrhea and you want to abort the diarrhea, you don't have to add water to it. You just give the patient straight milk of magnesia without adding water to it, and that will stop the diarrhea. So it works in two ways. So you always have to be careful. If not, if you're going to give the wrong it will cause more harm. Okay, so I have some mnemonic, but I'll try and even share the slides with you guys. I'll share the slides with you guys on WhatsApp. Those of you who are on the page, I'll try and share the slides with you guys. So the mnemonics are in there, and then you can have a look. So let's go through the intestinal obstruction itself. Just a moment, please. I hope you are enjoying the video. If you are not enjoying it, you can let me know. Just write something. Let me see. If you are not enjoying it, just let me know so that I can go and sleep. So when it comes to intestinal obstruction, that one is the total, okay, the total cessation, the total arrest, okay. This one says it's a blockage that keeps food or liquid, gas, and other substances from passing through the small intestine or large intestine. Okay, fine. But I don't like this. I don't like this definition. But this one is to make you remember, okay, how to deal with such cases. So, if intestinal obstruction happens, food, fluid, and then gastric acid, and then gases, they build up within the sites, behind the sites of the blockage. Okay, if enough pressure builds up, when the pressure builds up, the intestine can rupture, and this can cause leakage of harmful contents within the stomach into the abdominal cavity. So that is why once you get an intestinal obstruction case and you've confirmed this is intestinal obstruction, that is why you have to pass NG tube. Okay, this is why we pass NG tube. The reason why we pass NG tube in intestinal obstruction cases is that it can cause, there will be tension in the stomach, and then it can cause a rupture. The rupture will lead to leakage of the gut contents into the peritoneal cavity, and that will lead to peritonitis. We don't want that to happen. So the first thing you do, you pass NG tube to decompress the abdomen. Pass NG tube to decompress the abdomen. Because if you don't do that, when the obstruction is in the ileum, they'll have to go and do an ileostomy, and that is expensive. Okay, if it happens in the big intestine, they'll have to do a colostomy, and that is also very expensive. You wouldn't want to subject somebody's child through those things. So you pass your NG tube, you pass your urinary catheter. Why are we passing urinary catheter? Because intestinal obstruction case is not your case. Intestinal obstruction case is not your case. So when such a case comes, one, assess airway for patency, okay, especially for children, to be sure if whatever he has gone to swallow, some is not even still stuck in there. And then, when something gets stuck in there, let me use this opportunity to explain. Something gets stuck in the the upper airway obstruction or something like that. We have something called the back slap, jaw thrust, and chin lift. You have to go and read those things. They are resuscitation strategies. Later on, maybe I'll share those information with you guys. Okay, so I hope I'm not talking too much. So you have to pass an NG tube so that there will not be rupture. Okay, there will not be rupture and there will not be leakage of gut content in the peritoneal cavity. That is why you are passing the NG tube. 2, you are passing catheter because it is not your case. They might take the case to theater. That is why you are passing catheter. So you say assess airway for patency, ensure breathing, ensure circulation, and then you can do a digital rectal examination, secure a large bulb cannula, okay, or insert a large bulb cannula. Anyhow you want to say it, you can say it like that. Pass an NG tube catheterization to decompress. The exam the men control NG tube. Sorry, nasogastric tube. Be specific. Okay, you insert or you pass a nasogastric tube to decompress the abdomen. You understand? You can even add, if you want to prevent rupture, okay, intestinal rupture or something. That is when you read something and you are comfortable with that area and there is a time to do showmanship. That is when you do your showmanship. You don't do showmanship with your diagnosis, because if you go and give wrong diagnosis and then the management becomes something else and then you realize that we didn't quite. So the only time you can do showmanship, you do showmanship with your management. Okay, with your management, that's when you do showmanship. So after you've inserted large bulb cannula, you start with your crystalloids. That is, if you don't even want to be specific, or you say you administer IV fluids, okay, because you can't go and write something before maybe your family wishes to go and put dextrose normal saline, or they go and put something weird over D5 or D10 or something. Just say pass NG tube, ensure urethral catheterization, secure IV access with a large bulb cannula, start IV fluids. Okay, don't go and say anything weird. Okay, and always be monitoring, be looking at the vitals. When they give you a case, look at the vitals. Maybe they can give you the same case but the temperature is 39 point something, then that changes the narrative of the whole story. These cases, for example, all of them are likely to come with normal temperatures. You understand? So you have to look at the vitals. Look at, once they tell you a case of intestinal obstruction, but the temperature is 33 point something, the patient, there was rebound tenderness, this, that. You are looking at peritonitis and you are looking at sepsis. You understand? Atra, whatever you want to do, no, it has skipped that level. So you always have to pay attention with the question. Once the temperature has dropped or temperature has gone up, you should be thinking about, when the temperature is way too high, like 39 point something or 40, then you should be thinking towards sepsis and whatever it is. It means that whatever might be happening has ruptured and has entered into the peritoneal cavity. So there is going to be peritonitis and there is going to be sepsis. So there will be what? Rebound tenderness, guarding tenderness, and then generalized tenderness. Okay. Those who just joined, don't worry. The link, you can always click to watch the whole thing. Just that it's going to be very lengthy, so I don't know if you would still want to. So with the mechanical obstruction, the mechanic, don't even think plenty. Don't even worry yourself about anything. Okay? What are the types of intestinal obstruction? There are two types. We have mechanical obstruction, and then we have functional obstruction. Everything you know that causes the obstruction is the mechanical obstruction, and then the functional obstruction is the paralytic areas. So what are the mechanical obstruction? I've already said it. Volvulus, and the volvulus comes with vomiting. Volvulus is seen mostly in children. Intussusception is also called telescoping. So with intussusception, the intestine, okay, has entered entered into the next intestine that follows. Okay, so that is what is called. That's the reason why they coined the word telescoping. Okay, so you always have to remember, intussusception is normally seen in children within the age of 3 months to 3 years. So this one, it can come in the obese. Which of the following people are likely to experience intussusception? Then they'll give the years. Then you have to remember it is 3. So 3 months to 3 years. Why? Because that is the time their parents have been trying to switch. 3 months, some parents try to switch their meals. So in the attempt to switch the meals, the child will now is likely to have intussusception. Maybe the child is not ready for solid meals yet, but you see some mothers giving their children banku and fufu and all other stuff. Meanwhile, the child is an infant. The child is probably 3 months old or 2 months old. You understand? So with intussusception, that is it. So how will an intussusception case present? So the mother will tell you that the child vomited, okay, and the vomiting is fecal. It smells like physis. I don't know if you can hear me. Okay, so the child vomited and the vomitor smells like physis, or the child has been vomiting, and then the poo-poo of the child appears to be jelly-like or shiny. It looks like a jelly nature, as a shiny, like a pearl. Well, I've seen it before. That's what I'm trying hard to explain. It looks like a shiny thing, be like that. So when you see that jelly-like stool with blood-stained jelly-like stool, and you see abdominal distension, and the child is below 3 years, 3 years, 3 to 3 months, 3 years, 3 months to 3 years, then your clear diagnosis should be intussusception. There are no two ways about it. And MDC, nobody wants to trick anybody. They want everybody to pass. They are good people. So they'll tell you that, the mother says that the child had a jelly-like stool, a blood-stained jelly-like. Once you see jelly-like stool, and the child is below 3 years, don't think. You understand? Because before a condition will come with jelly-like stool, not check. Because jelly-like stool, blood-stained jelly-like stool, with vomiting, and then there is some form of constipation, is intussusception with abdominal distension. So with that one, there's a tube we pass into the anus of the child. We use there's a barium solution they do, or they have some form of air they pump, and it straightens. Those ones are for the surgeons to do. So they pass the tube. It is guided by, I think they look through an image, and then they pass it through with the barium through the anus, and then they inflate it. So once they inflate it, it goes there and corrects the intussusception. But don't try this at home, please. Leave it for the surgeons to do. Okay, so we now all agree, jelly-like stool, abdominal distension, jelly-like stool with blood-stained, abdominal distension is intussusception in 3 years old child. Is intussusception. Okay, so with that being said, let's go on. um we were on mechanical obstruction or mechanical causes of bowel obstruction. So we are looking at volvulus, we are looking at intussusception, foreign body ingestion, okay, foreign body. You are looking at hernia, okay, you are looking at hernia, you are looking at GI malignancies, like tumor, like anything wicked, okay. I'll also give you people the shortcuts, the mnemonics for the mechanical obstruction, so that you can remember. It's called the shaving. S for something, H for something. I'll give people the mnemonics so that you can always remember. Okay. So with the functional obstruction, it usually involves the nerves. And you know the nerve that supplies the abdomen. They are usually parasympathetic nerves. So with the gut, when if you want a case of paralytic ileus, they'll tell you, oh, a patient went to have a surgery, then few days after the surgery, the patient couldn't pass gas or stool. On auscultation, bowel sounds were absent. They have given you the clue. It's paralytic ileus. Some form of intestinal obstruction which is associated with surgery, okay, is paralytic ileus. No two ways about it. You don't have to think twice about this one. Okay, so we have with a mechanical obstruction, we have adhesions and scars, we have foreign bodies, gallstone ileus, we have hernias, impacted stools, intussusception. I've already said that already. We have tumors, intestinal atresia, diverticulitis, inflammatory bowel disease, endometriosis. Okay. Are you people enjoying the session? Is it interesting, or I should go and sleep? Okay, somebody said okay, they are enjoying it. Oh, okay, thank you. At least that brings my spirit up. Okay, so when you have, what are the signs and symptoms? With the signs and symptoms, signs are the things you see, okay. Whenever you get confused, remember signs and wonders, okay. So maybe Jesus did signs and wonders. So when Jesus is doing miracles, you see with your two eyes, isn't it? So sign. So the signs you see, you are likely to see peristaltic movement, okay. You see, say, there's something moving up and down. That is for in the case of constipation, you are likely to see peristaltic movements. Okay. When it comes to intestinal obstruction, you see abdominal distension. This one is pot belly, it's not abdominal distension, so nobody should look at my arms. It's pot belly. I'll start exercising. And then the sign, we have the constipation and then cramping of the stomach. So there's excruciating pain in the stomach. And then there's vomiting. The vomiting is, there's a word, fecal something. There's a word for it. I'll look for it. Is it feculent vomiting or vomitus that smells like feces? Okay. Severe bloating, large belly constipation. Okay, these are not too. So normally, normally intestinal obstruction cases, they normally come with vomiting, and the vomiting smells like feces, okay, with abdominal distension. It's up to you to find out why the abdomen is distended, and I've already told you from the beginning. I only forgot to tell you hemorrhoids. Hemorrhoids can also block the perianal. In an attempt to do your digital rectal examination, you inspect for hemorrhoid, you inspect for skin tag, all those things. Before you wear your 2 gloves, don't wear one, wear 2 gloves. You apply your lubricant or your normal saline. You use this finger for the examination. You use this one, the pinky, for children. Don't go and use this one for children. I beg. You go to court. Anyway. So in children, intussusception is the most common cause, and then the type of is the most common cause and the most type of intestinal obstruction that is difficult to diagnose in infants because they cannot describe their symptoms. Guys, please give me 2 minutes. 1 minute. I'll be right back. Sorry about that. So they are saying intussusception is difficult to diagnose, but today I've made it so simple for you. Jelly like stool, jelly like blood stained stool. Okay, jelly like blood stain. I'll look for a video, maybe a picture of it, and send it to you. Jelly like blood stained stool, abdominal distension, what again? Vomiting. Okay, abdominal distension, vomiting, jelly like stool, intussusception. Don't think plenty, because so far in my entire life I've had 3 intussusception cases. One, they said the child was like 3 years or so, I don't remember, or no, 3 months or so, and the mother was giving the child Tuozafi and some other things, and then the intussusception. So the child came, they were hiding the bloody jelly like stool, and that was the main thing for diagnosing the child. They went to hide it, and so I was suspecting this woman. So I was passing by, then I saw the pampers of the child, saw blood in it. Then I looked at it, I saw jelly like stool, abdominal distension, no intussusception. Straight. Don't think plenty. Okay, straight. Then I referred, because intussusception cases, they are not your cases. It belongs to the surgeons, pediatric surgeons. Let them solve their problem. That is why when you meet a case like this, you will never meet intestinal obstruction case in a medical question. It always appears at the surgical part. Okay, so as part of your management, after you've said in NG2, Y and catheterization and IV fluid and whatever it is, refer to see a surgical doctor or a surgical specialist, or refer to see a surgeon. If you fail to write refer to see a surgeon, you have failed. I'm not saying you have failed, but if you fail to write refer, because you are seeing intussusception case and you have not written refer to see a surgeon, are you planning to manage the case yourself or what? This job, everybody have their own I don't know, there is a part everybody plays, so don't go and play somebody's role. Once you have diagnosed it, your job is to diagnose it and give it to those who can do it, because if they don't do it, the patients can die. Anyway, so what are some of the signs? How will you know that the child has intussusception? So sometimes they will lie down like this, okay, and bring their knee towards their chest. I'm killing myself to explain this so that it will be in your mind, so that you won't forget. So they bring their knee to their chest, okay, and then you see them grunting in pain, passing of stool that appears that have blood in them, and then they are known as currant jelly stool, and then they have a very loud cry, vomiting, particularly bile-like vomiting. We call it the bilious vomiting. You see them, they look very weak. Okay. Uh-huh. Also, possible key findings. You see visible peristaltic movements. Okay, you look at their stomach and you see visible peristaltic movements, and then you look for scars. So once you look at the abdomen, you've seen a scar, surgical incision somewhere, then it means you are likely to be suspecting adhesions. Once you've seen a scar, it means the person has done surgery, so there can be adhesions. So that should prompt you that, oh, could it be adhesions from the previous surgery the person did? That is it. And then abdominal distension, I think we've done that. So you do your inspection, you do your palpation, and then you are looking out for guarding, and then you look for the hernia orifices. I think I've said this before. So with the palpation, you palpate the abdomen. It will be tympanic. You auscultate it can be tympanic or down. Yeah, it can be tympanic or down. So you auscultate the abdomen, and then there is high or increased bowel sounds. I was telling you, in mechanical obstruction, there is increased bowel sound, high pitched. Okay, in paralytic ileus, there are no bowel sounds because the nerves that are supposed to supply the bowels to be contracting and relaxing to propel the gut content, that thing is not there. Okay, so in paralytic ileus is absent. In mechanical obstruction, that is intestinal obstruction, such as intussusception, volvulus, whatever it is, and everything, foreign body, inflammatory bowel, everything, diverticulitis or whatever it is, high-pitched sound. So put it in your mind. If they tell you the person went to do a surgery and whine, paralytic ileus, bowel sounds, it will be absent. You understand? Put this in your mind. If they tell you the person went to do surgery and then, no matter the story, the person went to do surgery and when happened and then, and so the person is no longer passing through, there is no gas, there is then, paralytic ileus. When they tell you, oh, the person had hernia or there was intussusception or whatever it is, mechanical obstruction, so there'll be high-pitched sound. I'm repeating it so that it will stick in your mind. Okay, so with the labs, you are doing BUE and creatinine because the person is likely to do a surgery. So you are doing surgery because the person is likely to do surgery. You need to know the creatinine level of the patient, because once the creatinine level is so high, the eGFR is likely to drop. And so when the creatinine is so high, about maybe 1,000 creatinine, no surgeon would like to work on. But the creatinine level is, I think creatinine level should be around 80 thereabout. If your creatinine is 80 and below, then that is normal. 80 to 85 thereabout is okay. But people with chronic kidney disease, they can have as high as creatinine level as high as 800 and even 1,000. Yeah. So you have to do BUE and creatinine. Okay, you have to do BUE and creatinine. You have to do urinalysis. Also, the reason why we are passing the urinary catheter is to monitor fluid intake and output. Okay, you are monitoring you are looking at the kidney, the urine. Is it cola-like urine? Then you realize that the kidney is also now involved. Cola-like urine, or is the urine bloody? Okay, then you are looking at something else in addition. That's what makes you special. Discovering something else in addition to the main thing that is happening. That's what makes you special. So you do your full blood count. When they tell you what investigations will you do, that thing is a trap. Don't go and write only laboratory investigations. It's a trap. So make sure you write imaging. You write your imaging test, your imaging request, and then the laboratory. So you say, oh, erect a plain abdominal x-ray, erect and supine. Number one, so that you don't forget, because it's likely to forget. It is easy to remember to forget the imaging aspect. So plain abdominal x-ray, erect and supine. Okay, then the next thing, full blood count. Why? Because the person might end up with a surgery. The surgeons, they cut. While they are cutting, you have to make sure that the person has good hemodynamic state. Also, you have to do the simple thing you can do. The person is vomiting, he hasn't poo-poo, so you have to think about the sugar. So RBS, okay, those are simple labs, but they are very life-saving because the person has been vomiting. Because of that, he cannot eat, so you have to check the sugar. So RBS, plain abdominal x-ray, erect and supine, RBS, full blood count, BUE, and creatinine. Okay, you can also add LFT because there can be hepatorenal syndrome. You may never know. Everything can just pass in few minutes when it comes to medical setting. So with the x-ray, we are looking at air in the large bowel. I think that, yeah, air in the large bowel. We are looking at hostration. It's not in the book, but that's how we call it, the hostration, or the hostration, especially for the large bowel, the large colon. It appears like beads. Okay, we call it the hostration. And then you look for air fluid level, and then the small bowel or the bowel will look dilated, obviously. So in the case of intestinal obstruction, you use the barium enema. I was trying to explain, but barium enema. So far, I think that is it. So differential diagnosis. What is the differential diagnosis? You are looking at abdominal hernias. You are looking at appendicitis. Not for diverticulitis. Oh no, I don't think these are all. Okay, so these are diagnoses you can find within the intestinal obstruction. So that's gallstone. We all know gallstone can cause an ileus. So the gallstone, it obstructs the bowel duct, and then causes. Later on, we'll look at the physiology of that one. It's a whole lot of mechanism, but it ends up blocking the duodenum, and then it causes an ileus. But there's a whole mechanism attached to it. You can also go and read and come and watch me. Like I said, I'm a tilapia. You are the shark. So yeah. So the differential diagnosis, which are you can pick from the main diagnosis that can cause intestinal obstruction. You are looking at diverticulitis. You are looking at gallstone, ileus, and some other stuffs. Okay, I know you people are good, so I won't bother so much. What are some of the complications? Fluid electrolyte imbalance. Okay, fluid electrolyte imbalance. Dehydration. So you have to learn about dehydration. Is it severe dehydration or some dehydration or no dehydration? You have to look into it. Okay. I won't even talk about it. But when you see sunken eye, okay, you see sunken eye, loss of skin tegel, and then the person does not drink at all, okay, then that is severe dehydration. You need to have 2 or more parameters, okay, to conclude. And then once the patient drinks eagerly, and then there is no sunken eye or anything, then yeah. So we'll look into those ones as well, because it can also come. Okay, once it has crossed our path, where we have to look at it. Okay. Okay. So there can be perforation of the intestine. I think we've touched on all this. I said there can be rupture, and the rupture will lead to peritonitis. The peritonitis will also lead to sepsis. If you still don't understand anything after this discussion, you can put it on our platform. We'll discuss, because here is the roadside. If you have any further question, you can still ask in the group. Also, there can be tissue death or ischemia. Ischemia will lead to the tissue death. There can be adhesions, Gary's obstruction. Adhesions or Gary's obstruction. So when it comes to volvulus is purely surgical. There's nothing really you can do. Once there's volvulus vomiting, there's nothing you can do. Okay. So as part of your management, you always have to try to put the patient on broad spectrum antibiotics, because you are suspecting peritonitis. You understand? That is also more bad. So you insert your Foley's catheter, you pass your NG tube, you rehydrate with IV fluid. You pass catheter to monitor urine output, and then insert 2 large bulb cannulas. Assess airway. So assess airway for patency, breathing, and then those are the first thing. And when it comes to MDC exams, the reason why people usually fail is that, I'm coming. Let me see if I can get something to explain to you. Okay, so let's say something like this. Is this thing coming? I don't know if you can all see. So you see the lines. So the lines are few. So you write assess airway for patency, comma, on the same line, ensure breathing and circulation, comma. You understand? That's how you do it. Or you write 1, assess airway for patency. 2, on the same line, you then write 2, ensure breathing. 3, ensure circulation. On the same line. 4, pass a urethral catheter to monitor urine output. 5, insert 2 large bulb cannulas for IV fluids. Okay. 6, pass an NG to a nasogastric tube to decompress the abdomen. 7, if there is more space, take blood sample for laboratory investigation. 5, if there is more space, cover patients with broad spectrum antibiotics. Ogbena, kalas. But if you say you write everything for every line, it will not go. MDC, they give you few lines, like 1, 2, 3 lines. So if you say you write everything 1, 2, 3, ebe manasa, wonchro nyansasembia, so not line asa. So 1 line you write 1, then you circle. 2, let me see, 1 line, then you or 1, assess airway for patency, breathing. Assess airway for patency. 2, ensure breathing. 3, ensure circulation. And then normally it depends. In some of the cases, you ensure disabilities, okay, such as in traumatic cases such as cervical spine alignment or dilatation, okay. And then in case of alcohol or a child who has gone to drink petrol or anything, so you look at the exposure, E for exposure. So you see, if they tell you brought unconscious, who is suggestive to have drank something, so you add the exposure. What does the patient smell like? Does it smell like palm wine, or he smells like alcohol, or he smells like what? So you have to put those ones there. Okay. Okay. So the management of hernia, we all know, once the patient comes in, it tells you he has hernia. It's your duty to find out whether it is reducible or irreducible. Reducible, you ask them. So hernia, you have to let them stand, okay, so that you look at the the scrotum, okay. If the scrotum, if after they stand, you look whether it is more to the left or more to the right, okay. And then you let them lie down, and then you try and push it in. So if you are able to push it in, then it is what, reducible. But if it is not reducible, when you try pushing it in, it will not go, okay. And you have to do it gently, so that, because it's painful. And then what else? How come I'm lost in thought? This is strange. Okay, so you only have to be gentle with it. You try to push it gently. Also, when you hold the testicle, try to palpate it. See if you can get above the swelling. When they stand, try to see if you can get above the mass. Try to palpate the spermatic cord. Okay, those are the important things. If you can get above it, that's fine. Also, when you palpate it and it feels like a bag of worm, okay, you palpate the testicle, it feels like a bag of worm. It's no longer, you are not dealing with hernia anymore, you are dealing with hydrocele. That is there. So MDC can tell you, upon palpation, it feels like a bag of worm. Bag of worm is hydrocele. Okay. It might be pyocele, but pyocele is a little harder. Okay, a little, not too soft, not too hard, but yeah. So that is how it looks like. So ladies and gentlemen, I think hernia there it's a whole case, it's a whole course on its own. So we'll just leave those ones for you to deal with. But I'll share the slides with you, and then you realize that the slide it contains a lot of things. It's plenty. It talks about barium enema. So when I share the slide with you, you can play back this video whilst you are going through the slide. I think that will give you clear. It took me like 4 days to prepare these slides, so I'm sure this will help you. It will really help you. Okay, ladies and gentlemen, I think we have come to the end of today's discussion. So all we have to remember is that in every intestinal obstruction case, plain abdominal X-ray, erect and supine, full blood count, okay, full blood count, BUE and creatinine, RBS, because the person hasn't eaten for a very long time. You now do urine dipstick to check if there is proteins in the urine, or there is blood in the urine, or glucose in the urine, something, okay. And then we spoke about mechanical obstructions, which can be adhesions, intussusception, volvulus, hernias, inflammatory bowel disease, diverticulitis. All those things are likely to cause. So let's go to the easy way to memorize these things. Then we'll be done with today's discussion. So we have um, shaving. Shaving. So shaving is for small bowel obstruction. So with the shaving, S is for stricture, H is for hernia, A is for volvulus, I is for intussusception, and then inflammatory disease. Um, and then N is for neoplasm or neoplasia or anything. And then J is for gallstone. So shaving, okay, shaving, that's where the mnemonic is. S is for what? Strictures. H is for hernias. A is for adhesions. V is for volvulus. I is for intussusception and inflammatory disease. And then neoplasm for N, G for gallstones. And then we have the ABC. The ABC, A is for adhesions, B is for bulge, such as hernia, and C is for cancer. So if you cannot remember the shaving, you can remember the ABC. And ABC, A is for adhesions, B is for bulge, C is for cancer. Okay, let me see. Okay, so I've put in all these things together. Now when it comes to paralytic ileus, we have 4P, PPP, PPPP. That's P for post-operative, another P for peritonitis and pancreatitis, and another P for potassium, uh, potassium. That is, okay, I spoke about Parkinson's disease, someone being on medication. So low potassium from Parkinson's disease or painkillers. And then the next P is for pelvic and spinal fractures. Okay, so ladies and gentlemen, we have come to the end of today's discussion. If you have any question, you can put it across. If you don't have a question, if you want to send it to us in the group too, you can do that, and then we'll go through and see the best way to approach it. So I'll leave like 5 minutes for us to, if you have a question, you drop it in there, and then, so 5 minutes, I'm waiting for 5 minutes. I'm waiting for questions. So questions. Hey, or everybody is asleep. Hey, as someone, I'm the only one here. Everyone is asleep. Any question? Okay, we'll revise I'm seeing some message here. Let me just go. We will revise and get the questions in the. Oh, okay. Okay. So then I think, ladies and gentlemen, we have come to the end of today's discussion. Thank you all so much for coming. I'm very grateful. And then I hope this discussion has been very insightful. Forgive me, it's been years since I completed school, so everything is gone. I'm trying to bring everything back. So once everything comes back, we will enjoy. Anyway, thank you all so much for joining this discussion. Bye. How do I end the live? Hey, I actually want to stop stream. Yes.